Good evening, everyone. If someone can just give me a thumbs up, make sure you can hear me. Someone give me a thumbs up if you can hear me. Perfect. I see Jess's thumbs up, so we're good. Just a couple quick things here before I let Ron get started. I did upload the PowerPoint handouts to our website on our webinars page. So I put those up this afternoon, so they are there. If you want to go there now, you're welcome to. Sorry, I went to Zoom to see if there was any way to like email everyone who was registered, and there wasn't a way for me to link to that. So I'll try to look into that and see if there's a better option for next week to let you all know. But otherwise, just look for that maybe an hour or two before the webinar, and I will try to post handouts if we are going to use handouts. One other thing that I didn't mention last week, I know some people aren't super familiar with Zoom, but are becoming more familiar with these times. You have the option to switch views. So you can see a picture-in-picture view, a side-by-side view. You can just view the speaker view. You can view the gallery view. And if you're on a computer, you can do that in the top right-hand corner. You'll either see speaker view, gallery view, or your options. If you're on a tablet or a phone, you want to swipe either left or right to have that option. So I just wanted to kind of give some people a little bit of information there in case you are wondering how to change views. But we do have another PowerPoint. Ron has a few more slides this week, so we will try to answer questions. If we don't get to questions, I promise we will. I did turn on a chat feature tonight, so if you do have questions related to what he's talking about tonight, feel free to send those over to me, and if we have the opportunity to talk about them at the end, we will take a look at that. But otherwise, sorry, someone just said they have their volume all the way up, but it's still kind of low. Everyone hearing loud enough? Thumbs up if it's loud enough, or do I need to be louder? Thumbs up? Okay, I will try to adjust that, Jen, as we get started here, but it sounds like most people are okay. And I'll try to keep this lapel up higher towards me as well. But I will go ahead and let Ron get started here. And like I said, if you have questions related to tonight's presentation, please feel free to chat those over here to me. And we will try to address, maybe one or two at the end of tonight's presentation.
All right, Jen, thank you so much. Good evening, everybody. Good evening. And thank you for joining us, and thank you for the company. I know we have more than an hour of slides and discussion, but I will try to go slow, but I know my speed of slow is usually fast. The nice thing about this webinar series is you're going to have access to all this written information, and I appreciate, Jen, your effort in getting that out. Jen asked me this afternoon, Ron, what do you want to call this talk this evening? And I said, Jen, I gave her, I think, 4 or 5 different titles, and here's the one she selected, and I like it. The roots of lung function. This is the roots of lung function. And we're going to talk about how this trachea and its branches into your lung tissue support your windpipe, support your activities around the front of your spine, and how those 2 lungs give you the sense of composure when it comes to breathing. And for that matter, when it comes to any type of activity you do when you use your 2 sets of extremities. So I'm looking forward to this. I'm going to start off by talking right away about what we are going to try to accomplish this evening. I'm going to try to cover as much as I can, not in a lot of detail, on how we maximize our lungs for centering of our body, of our trachea, as I said earlier, of our spine, our spinal column. We'll talk about how to provide compression to the lungs. And there's a kind of, I believe, a big elephant in this room right now, and that's called dead space. There are a lot of patients you're working out with right now that do not have the space they need and the space they should have in their bronchial tissues and their airway sacs and their airways that they could have if you help them reportion that lung, reposition that chest wall, and get them to move a little bit more in the manner that they're not. So during inspiration, lungs should expand, and unfortunately some don't. We're going to talk about the dead space that's associated with that, the lumen of the vessels that go into your lung and the lung itself. How to begin repositioning the chest wall for reportioning. That's a word that means you're going to cut up a pie. You're going to reportion that pie. We got parts of our lung that are very well known for perfusion. We touched base on that in the last webinars week we had, and are very well known for ventilatory activity. Unfortunately, there are parts of our lung that need a little more perfusion, a little more ventilation, and we're going to associate that with what's going on with the posture that's connected to those lungs, covers those lungs, by looking at the chest wall. So on how to begin repositioning the chest wall, just basic concepts that I think we should all be aware of. In the manner that you move, and the reason why you move in the manner you do is all related to the posture you have, the position that you were put in when you developed and became behaviorally minded on how not to fall. So those respiratory zones that these bronchioles go to, that bronchial tissue goes to, will also be impacted by how you reportion that lung pie, that lung surface, that lung region that we're going to refer to as apical and base this evening. Our respiratory tract really has two parts. It has an upper airway and it has a lower airway. And we're going to break that down tonight, but we're going to start with the upper airway right off the bat. And I won't get into a lot of discussion about nasal passages or the concha of your nose, but all these things that you have in front of you are in the upper airway, including the portion of the larynx that's right above the vocal cords. So some people consider the vocal cords part of your upper airway. I do. They are the division, if you will, between the upper and the lower airway tract. So you have your nose, your nasal passages, your paranasal sinuses, your pharynx, and obviously the larynx and the vocal cords. And then on the lower airway, down below the vocal cords, you have your larynx, the trachea, and the trachea is something we're going to talk a lot about tonight. We have a primary, secondary, and tertiary bronchi on both sides. Remember, this is a hemi-lung. You've got lungs on one side, and you have lungs on the other side. So you have these primary, secondary, and tertiary bronchi that go to each side of your chest wall. And then you have these little bronchioles that feed off of those. And that division then finally gets into your alveoli and your alveolar sacs. And that's what makes up your lungs. So the lower airway is where we really need to be mindful of portions, things that need to be divisioned off and maintained in their size and shape, if at all possible, through any phase of life. The upper respiratory tract and the lower respiratory tract, I think you have this diagram in the handout or in the slide that they're looking at. Is it on a slide? Yep. And again, just to remind you that you got a nasal cavity, a pharynx, a larynx, and then you got the trachea and the primary bronchi and the lungs. Now, when you look at this picture, the first thing most people do, Jen, is they look at this and they think everything's going from either the nose and the mouth down, or it's coming up through the trachea. And you wouldn't be wrong if you thought that there's two ends to that upper and lower airway. But what you got to remember is that there's pressure going on between those two ends. You have air coming in and out of the upper airway, and you've got air going in and out of the lower airway, but the external air is only coming from the top, as you all know, and the lower part of the airway is responsible for what's going on inside your body. Your body's actually producing gradients of pressure that's moving air up and down, and sometimes that air gets very trapped, very stagnant, and it can't move very well. What's going to move it is the actual location that you put those lungs in to give it the force it needs to get the air out, to expel even contents that you might swallow accidentally into your airway. So when I look at this, I'm looking at it from two angles. I'm looking at all this sensory information coming in through your nose that you breathe with, you filter with, that goes through the back of your nose and your mouth, and even your ears. You can breathe in through your ears. And all that airway, all that air is coming in and being pulled down or pushed up. Two words you should probably write down. The upper airway pulls things in for you I know your diaphragm is doing the pull, but air comes in through a pulling mechanism with that upper respiratory tract. The lower respiratory tract is responsible for push. That push comes from rib cage and intercostals and muscles that you compress things with. So the push-pull mechanism is what restores portions of your lungs when any movement that you make is directional. So if I go left, right, reach down and up, do anything I might do with my arms and my legs, that push and pull is a give-take relationship, and that gradient of pressure meets in that trachea, somewhere in that airway between the nose and the mouth and the ears, and down there in that lower part of your lung, there's going to be like balloon-like activity going on with every step you take, everything you pick up, everything you push, everything you pull, everything you raise up, and everything you reach with. Keep that in mind as we go through this talk this evening. So it's a constant living system. The lungs are opening and closing because that's life. That's normal. When lungs don't open and close, your nose knows it, your mouth knows it, your tongue knows it, your ears know it, your vestibular system, which is responsible for balance, knows it, your spinal column knows it, your 2 feet know it. Everybody's going to know it when that windpipe is starting to be twisted because you can't move that pressure, that gradient of pressure around like you should, because you're locked into a pattern, locked into a position. And unfortunately, most people will look at this as being a postural issue coming from external muscle, external bone, which I do. I'll be the first to tell you that. But we forget that the air in the tire of the car that you're running it on, these 2 wheels that have air in them, are sometimes responsible for your inability to move in and out of a position that we don't see, feel, or even sense. So make sense of that tonight. We're going to look at these roots of this tree that has a trunk to it. And that tree has a trunk from the base up, and there's a tree trunk that's coming down from roots that are up here in your head as well. These little concha, these little vesicles that you breathe in through are filtering air for you, just like you're filtering it down there in your lung tissue. And that constant movement of air between those 2 filtering systems allows you to smell with your nose, taste with your tongue, and then it also allows you to, filter particles out in through your chest wall with mucus on the sides of those walls of those bronchioles that collects that dust, collects those particles, so you can cough them up, spit them out, and get them out. So beautiful ventilatory system. We aren't even talking about perfusion right now, exchange of oxygen and exchange of gaseous carbon dioxide with oxygen. We're not even into that discussion right now. All we're talking about is the gradient of pressure that is constantly being managed by oriented diameters of surfaces that are constantly dancing around in your body, and we're made to dance around your body with this soft tissue called lung. Okay, so you got a trachea, and you got one of those. You have roots, you got many of those, but we got 2 roots, this hilus area that we'll show you a picture of, that allows you to branch off from the trachea into both lungs. So we have this main stem bronchi that comes off that. The lungs are connected to the upper airways by the trachea and the main stem bronchi. The trachea is a tree trunk. It's got cartilage around it. It's got support from the spine and behind. It's very, very mannerly. It will follow the lung tissue on both sides of it. It's supportive and it's supporting, and it's the main stem of life. It's what we actually pressurize ourselves with. It's what we break falls with. It's what we push ourselves up with. And it's how we reach and pull and raise up to the occasion. The root or the hilus of the lungs lies in front of the 5th, 6th, and 7th thoracic vertebrae. So the hilus lies right in that 5th, 6th, 7th area of vertebrae of your thoracic spine. The part or cavity inside our chest wall that houses the heart, the thymus gland, portions of the esophagus, and the trachea, as well as other structures, is called the mediastinum. It's a room. It's not a very big room. And I realized, like Jen said, that you can always go back and look this up and Google it. But Jen, what I did is I took our model and I just put some tape on some paper And I hope you can see this. I don't know.
Yeah, I'm going to zoom in on you just
So you have this area between the two sides of the lung. You just tell me where to focus this, I can see it. And this area where my hand is, it looks kind of like a pear. I don't know if you can see it or not. It's right behind the sternum, the lower sternum, in front of the 5th, 6th, 7th, 8th vertebrae, kind of spreads out on the bottom, is a room. And inside that room are all these parts that have a lot of mucus and space to move around in. It's the plumbing of your house. It's got a lot of pipes, a lot of vessels are moving around, sliding around and pushing around on each other and wrestling themselves. And that's what that room was made for. And then when that mediastinum stays open, life is good. That because you've got the ability to move your lungs around with a rib cage that's going to allow it, because there's enough movement in that area created by the back of your spine that's slightly rounded and the front of your thorax that's slightly rounded, that gives you the ability to work as you were to squeeze a sponge. So you got this sponge that's constantly being milked and pushed and sloshed around right between the spine of the column of the vertebrae, called the spine, and the back of your sternum that's compressing that tissue all the time. And that's the way it was supposed to work. It was supposed to work. You were supposed to have the ability to compress and decompress at your will, anytime you want. And here's what I think a lot of us don't realize. Every time we raise our arm up, every time I raise my voice, every time I lower my body, every time I lift a leg to kick, that area, that chamber in the front of those two lungs, in front of the spine, excuse me, underneath and between your two lungs, is constantly aware of that. That's where all your important information comes down to your stomach and to your heart and to your lobes of your lungs that all communicate through this brainstem at the base of your skull. So when you think about what we really do with behavior, what's going on between the two lungs, between the sternum and the spine and the two lungs at that mid-sternal level of your thorax is really, really important to keep protected. That's why God protected it. And as it not only protected, it's also allowed to do anything you want it to do when it comes to movement. There is no bone in there. There is no glue that keeps you together. So it's important to remember that that's the part of the cavity inside your chest wall that houses your heart and your portions of your esophagus, the things that you need to eat and breathe with, as well as support yourself up with internal pressure. For clinical purposes, this opening, this room called the mediastinum, is traditionally divided into the anterior, middle, posterior, and superior regions. So it's divided in those regions, and I'm going to talk a little bit about those regions tonight. And for the rest of this webinar series, we're going to focus on that posterior mediastinal region, and we're going to post it. We're going to really post it. We're going to make sure that that region stays open with everything we do with our techniques and our recommendations to keep your lung function where it should be. We're also going to be focusing on the anterior upper right region of the mediastinum, along with the contents above it called the lung, the anterior apex of that region. And we're going to be focusing on the posterior, if you will, middle part of that mediastinum and low. So the lower posterior side on the left side and the anterior lateral apex on the right side, along with its apex, we'll be focusing on as well. So when you say the word anterior apex, we're going to think about right side. When we say the word lower base or lower posterior lung, we're going to be thinking about the left side. Lower left, upper right. Lower left, upper right. And between those two areas in that oblique vector, you have this sandwiched mediastinum. We're going to talk a little bit about how that gets twisted, the position people usually get themselves in to untwist it, which are techniques that are going to restore portions that you probably don't use as well as you should in the lung and the chest cavity. Okay, at the mediastinum's apex is this hilum, the point at which the bronchi and the pulmonary arteries and veins, lymphatic vessels and nerves enter the lung. We kind of went over that. So this area right here is where the highways are and the routes that you need to take to these certain areas and the organs that are associated with it exist. I love this slide. And this is basically, I think, what came from, was it Wikipedia? I don't know, it came right off the internet, Jen. But I love this slide. You're looking at the top of a region around that 5th, 6th, 7th vertebral area of your body. So if I just slice, that's a pie. If I look at that pie and you slice it in a transverse view, you would see this. You'd see the pleural cavity on the right side, the lung hilum on the right side. You'll see the visceral pleura on the left side. It's pretty well marked. But what I really like is when you look down at those cut vessels, you're going to see ribs that are going down into the ground. You're going to see, not ribs, excuse me, roots that are going down into the ground. And I told Jen before we started this evening, it's such a cool slide because when you look at it, those roots that you're looking at are pulmonary arteries, pulmonary veins, and bronchioles going into the cavity, into your lung. And when those things get full of fluid, whether it's venous fluid, arterial fluid, or air with mucus in it, they become structurally pretty stable. So what you're seeing is roots on a ground surface on the right side and the left side, stabilizing the organs right in the middle of your body with a spine behind it. And the spine is the most flexible thing in the world until you start putting air bladders in front of it and bellows in front of it, which we're going to talk about. The lungs are bellows. So I see bladders and I see bellows, but what I really see are roots full of fluid and air that stabilizes the way you move your body. Without that transverse section depicting this, if you took all those contents out, including the heart and the pericardium, out of that chest wall, you took it out of that chest wall, this chest wall would basically collapse. You would be on the floor. So it's not the ribs that are holding you up. It's not the spine that's holding you up. What's holding you up is what you're seeing right inside that area. And obviously life is when that area is actually perfusing and ventilating and working. And so it's critical that you take a look at that. If you also take a look at it, you'll see that the right side is, and it doesn't do a good job of this, but you'll see the right side is usually a little bit larger than the left when it comes to the ground that those roots are going into. People with curvature of the spine usually develop curves in their spine because of the position, the portions that you see in that pie being distributed in an asymmetrical transverse plane. So you'll see that plane inside start to move around when the ribs go up and down, back and forth, and that spinal movement, that spinal column movement, that columnar movement is going to be either directed there, guided there, or restricted by the contents that you see on that diagram, as they're either compressed or decompressed, as either they're opened, decompressed, or they're compressed, they're closed. So that constant tension inside of us is what regulates our function. Posture is tied into the compression and the pressure that you see as a result of what's laying between the rib cage itself and the front and the back of the body, the sternum and the spine. The trachea, the root of the tree, is a flexible cartilaginous tube. It's a tube. It lies in front of our esophagus. It's protected by the esophagus. It comes down with a slight inclination to the right. All humans have their trachea over to the right more so than to the left. This rightward orientation complements the location of your stomach, the organs underneath the diaphragm called the liver on the right side, and your pericardium, your heart, right in the middle. It travels behind the sternum, as we talked about earlier, into the thorax to the sternal angle, where it divides at that sternal angle from the right and the left main stem bronchi. So you've got this main trunk with these roots coming down into your lungs. Now, why is this so important to talk about? We have to lay the groundwork to understand why certain techniques, why certain activities, why certain movement patterns will either close a region of that lung off or open it. And if you're in patterns of movement where your spine won't allow you to move, or the spine can't move because of these contents positions, If you don't work the spine and the rib cage correctly with the lungs, then you might be doing the spine a favor by getting it straighter or getting it more lined up with where you think it belongs. But underneath, those lungs are not liking it. So if you don't understand how to move the chest correctly as you lengthen your spine or shorten your spine or align your spine, if you don't do that correctly, you can actually cut off good airflow to areas of the lungs that you are not perfusing with or ventilating well enough with. And then obviously where that occurs, you're going to start to accumulate fluid. You're going to start to have space that's kind of dead, and now you're going to have to drain it somehow and pump it out of there. The tracheal wall is strengthened by 16 to 20 horseshoe-shaped cartilaginous rings. So these little rings that are in front, that are around that trachea, keep it from collapsing. It reinforces it from collapsing when the chest wall flexes or when you cough or extend. And again, that word reach, underline it, because we need to reach in these COVID times. When you see the word reach in this handout, just put another R word with it. Reaching is respiration. Respiration is reaching. So when we extend our back and we reach, that's respiratory activity. Things are starting inside to decompress on one side or compress on the other side, depending upon the extremity it's reaching more or less. So reaching or during rotation and lateral flexion from one side to the other, you'll see this tracheal wall being pushed and moved around inside. It is lengthened when the head and the neck extend or move back. That trachea is lengthened on the chest wall. During swallowing, which raises the trachea, and then during inspiration when the lungs expand and the trachea is pulled down. So when I take a deep breath of air in, my chest wall fills up, my diaphragm lowers, the center part of my inside of my thorax lowers. During that time, my trachea is being pulled down. The lower airway is pulled down when you take a breath in. When you extend your back or when you cough and swallow your food to get the food in your stomach, that trachea's got to go back into extension a little bit, and the upper airway moves up. So just by talking and chewing and swallowing, you're pumping fluid up and down into those lungs, and the trachea itself, this tree trunk, is swaying back and forth as the roots underneath of it are shaking around and jostling around with lungs that are moving. The ground is moving. It's the neatest thing in the world. And if you watch it on a fluoroscopy, you see all this activity, you think, how's that guy or gal ever going to stand this? What really happens is they're loving it, because the more of that activity you have inside of you, the more you're capable of doing things with your arms and your legs for freedom, for movement, for motion and stability. So keep in mind that the more you move inside, the better you're going to move on the outside. And the more you move inside, the more stable you're going to be on the outside. The ground is really going to be there for you the more you move inside. If that inside trachea inside of you is not extending and flexing, compressing and decompressing, then you're going to have to do that on the outside of your body. Your spine gets stiff, you age faster, your ankles wear out. Your bones shatter, the joints get a little bit more compressed. The more you move inside, the more that slide is allowing that trachea to move, the more you are going to feel the support and stability you need on the outside of that tree. And this is why I like this slide, because this is the tracheal bronchial tree. It's 3/4, if you look what's written on the top, 3/4 of it is rotated toward the right side on every single one of you watching this afternoon, this evening. And if you look at it, you'll see the right side's a little bit more linear, that bronchial tree. As it comes down, that trachea comes down, you'll see that the bronchial opening, the hilum on the right side, is a little bit more vertical than the one on the left side. The one on the left side is going out at an angle, because over there's another tree that's sprouting back on up. Do you see that left side? That left side's got another little bronchial area coming up. You all have that. You've got a little bit more flare on that left side of your lungs than you do on the right. But on the right, you've got 3 lobes. That middle lobe's got a little bit more airflow going to it. So the bronchial tree itself is not symmetrical. Asymmetry in your body really starts with this tree. Every one of you are asymmetrically minded because your 2 hemispheres of your brains are different. But your two hemispheres of your thorax are as different as the two hemispheres of your brain. I see a lot of patients who have strokes of their chest wall. One chest wall is not working. Just like if they would have a stroke of their brain. One side of their body isn't working. But when I see one chest wall not working and they have their brains and they're fine, that brain is struggling to get that body to work because one chest wall is not working. One chest wall is dead and the other chest wall is alive. Well, most brainy people that have two good hemispheres for brains will work both sides if the chest wall that's accompanying with that movement is capable of working. Well, the only way you're going to keep that brain and that chest wall happy working together is you got to make sure that the normal asymmetry that you're seeing on this slide is kept, which means you've got to do everything you can to keep that trachea in the middle of your body with the associated tree trunks that are on different parts of the ground. The left tree trunks are going to be a little bit spread out a little differently than the right tree trunks. And to keep that tree trunk happy and to keep the tree happy on top, you got to make sure that the shaking and the sliding, the swinging and the gliding is occurring on both sides. So take a chance when you have a little more time to look at those, where the orifices and these bronchioles and these tubes are going to the different aspects of the lung itself. I believe in these COVID times, we need to respect what this is filtering and what this is feeding. This is drainage. All the stuff that we're trying to get out of our lungs so we can use that lung tissue, it starts right here with the concept. I wonder if I have my bronchial tubules, my bronchial tree in the right position. I wonder if I need to reportion it a little bit, and how would I go about doing that if I was having difficulties with breathing, shortness of breath, or a challenge with all the fluid that I'm collecting and not getting out. The top and the bottom of the trachea is secure, protected, guided, and shielded by the sternum and the thyroid cartilage. We have this wonderful cartilaginous material around this precious trachea. In relationship to the center of the middle of the body, we depend on chest wall orientation. So its relationship to the center of the middle body depends on how we orient our body. If we like to stand on one side of our body and our body is oriented usually to the right more than the left, over time, the portion of airspace is challenged usually somewhere in that lung space. And that's what we're going to talk about towards the end of this discussion this evening. Where is that actually occurring, and what can we do to get that reduced? So in relationship to the center of the middle of the body, its relationship, the trachea's relationship to the center of the middle of the body depends on chest wall orientation, patterns of habitual lung pressure, cervical or neck placement, where you put your neck, how you hold your neck, and its position, and the alveolar dead space, the alveolar dead space. You all have dead space in your lung. It's not an unhealthy thing. It becomes unhealthy when its ratio to live space is getting a lot higher than it should. The trachea connects the upper airway with the lower airway, as we talked earlier. Air comes in and air goes out through these bellows that are pushed and pulled in your lung. You have these wonderful bellows. I'm going to show you this with this accordion picture coming up. Our alveoli are pushed and pulled by our chest wall movement from top to bottom, bottom to top, and from side to side. So here's this accordion. You know, you've got chords, I believe, on one side played with your fingers, and keys that play, you know, pitches or different sounds on the other side. And when that accordion moves, it has to laterally flex, side bend, if you will. And as it's doing that, it's pushing air in and out. And you've got two of these. You've got one on one side called the left lung, and you got the other one on the right side. When one is closing, the bellows on the other side are opening. If you move to the other side and the lung is closing, but the other side can't open, that bellow movement is not going to really occur very well. Humans love to take their accordions and they love to tighten up their right bellows really tight. We love to stand on our right side. We have our body oriented to the right. We start turning our upper body back over to the left, and we take that accordion and we side bend it on the right side. We open it up on the left side, and all the bellows on the left side are up in the air and opened wide, and all the bellows on the other side and the back are closed down. And that ability to redistribute that movement of air from the compression that accordion-like lung is going to make is now lost, because you don't have the ability to shift and slide and glide because of the location or the portion of lung that's either closed or open. We want to constantly make music with our lungs. We constantly want the keys to be playing different pitch. Pitches are made by the size of your lung cavities, your lung spaces. Some people have loud, long, high pitches. Some people have low, short pitches, low frequency of pitches. It's depending upon how your chest wall and the lungs underneath of it are being bellowed, are being moved from side to side in flexion and extension and opening and closing. I love this picture. This is a picture that I encourage you to go to, just in Wikipedia, just type in accordion bellows. We suck air in and we push air out. And when we suck it in, it goes through reeds, R-E-E-D in the accordion. Those are our vocal cords. Everything passes through our vocal cords. You suck it in through the vocal cords, it makes a noise. You push it, it makes a noise. And when we push and pull through our nose and our mechanics of our diaphragm, what you're really doing is not making a noise, but you're generating this wonderful gift of push and pull. So all of your work you have going on in your day-to-day activity is around that word, push and suck, push and pull. And that's a great picture of it in terms of relating it to the buttons and the keys on an accordion that push and pull airflow. It's a perfect picture of what we're talking about this evening. So you take that push and pull concept, you put it back on this diagram that's in front of you. You've got these lower trees, this branch of activity below in the lungs that has to be massaged and pushed, and there's this communication going on with the nasal cavity above. The nasal cavity, I consider part of your trachea. It goes all the way up to the nose, and when I see that hilum down there in your lungs, I'm thinking of how are you smelling? What are you doing with your nose? So it's all connected. The nose knows what's going on down there in the bronchial trees, and the bronchial tree down there in your lung knows what's going on behind your eyes and underneath that nose. And again, I look at this picture and I flipped it around. I told Jen, could you flip this around? What we did is we took, Jen, I'm gonna go back to the slide. We're taking that ground of bronchioles that you see in the lung on the base of that respiratory activity, and we're gonna flip it. And when we flip it now, what you see is a trachea that's turned upside down. Literally, you don't have bronchioles in your nose and in your mouth, but literally you have the similar activities going on between both sides of your nose and both sides of underneath your eye socket and in the chambers that you breathe with concha, that's called paranasal concha. So you got turbulence over here and you got turbulence over there, and they don't look too much different than what you see on that diagram right now. And then if you flip the thing around and go the other way, I think that's coming up. I hope, maybe it's not coming up.
Not instantly.
Okay, you just flip it around the way it was normally supposed to look. You got filtration on both ends, and right in the middle, you've got this trachea that's constantly directing the orchestra. So you've got players below and you got players above, and that orchestra has got to be regulated by a trachea that's right in the middle of your body. That's called an airway. And for that airway to stay in the middle of the body, you've got to be able to shift your body weight from side to side and reach with both arms like both are equally meant to reach with. So I thought I'd just show you that. That's how I look at it. The movement of the air through the lung and the trachea is dependent on the position our lungs are placed in, therefore. And accompanying the size of the trachea, root, and main stem branch. And accompanying size of the trachea, root, and main stem bronchi. Humans have a very strong tendency to follow the rightward orientation of the right main stem bronchus and the right upper lobe of your respiratory tree. Just say the word right. Humans love to follow their right respiratory tree trunk. They love to be over to the right side. We have 3 lobes over there. We only have 2 on the left. We need to understand these concepts, Jen, because we're going to get into the next few weeks on what are we going to do with certain techniques, certain activities to balance out this flavor of activity that you've got going on through your respiratory system that is asymmetrically challenged and asymmetrically minded, if you will. What are you going to do to keep that airflow going so one side of your portion of your lung doesn't, die off? The right upper lobe divides into 3 segmental bronchi: apical, top, posterior, and anterior. So remember that: apical, top, here's your apex, posterior behind, anterior in front, and then there's your base. So apical, posterior, and anterior. And you have the anterior and posterior and apex on the left side as well. Apex top, base bottom. The apical bronchus runs almost vertically toward the apex of the lung on the right side. I think I already mentioned that. And that is a key point. We do not have a tendency to go over to the right side because we just have bigger feet on the right side. We have a tendency to go to the right side because our airway wants us over to the right side. Your left brain wants you over to the right side too. But our airway wants us over to the right side. Our lungs want you over to the right side. That's where your most efficient breathing is going to be, with the right diaphragm over to the right side. But you can be very efficient on the left side if you move the trachea over to the left side by shifting your weight over to the left side, provided that there's no dead space hanging around that won't let you get over there. So over time, if you have this dead space associated with your body's orientation only to the right side, you'll start breathing from that point on, wherever that point is in your life, more with your body weight over to the right side, along with other factors that keep you over to the right side. I'm just covering pressure of airways and the space called dead space inside of you that puts you over to your right side today. This course of flow complements the right main stem's bronchus, which is more vertically minded than the left main stem bronchus. The right main stem bronchus appears to be in an extension of the trachea. Therefore, your trachea kind of goes from your nose, your mouth, all the way down to the bottom of the base of the right side because the way that trachea is lined up with that bronchus underneath of it. It's wider than the left. It makes it easier to breathe when you're on that side. People can breathe a lot easier when they're on the right side. However, people should breathe really well when they're on the left side, provided that everything on the right side can expand when the bellow is opening on the right side as you shift your body weight over to the left side. There lies in the problem. What are we going to do to keep individuals somewhat mindful of how to breathe efficiently when they're on which side, Jen? The left side. So that's what this whole webinar series is all about. How do we keep people efficiently breathing and perfusing and ventilating when they shift over to the left side? This is a young lady that's standing on her right side. She loves to stand on her right side. She's even got her hand in the bellow of the right side. But that's how you normally would see someone relaxed. They'll stand on the right side. The right shoulder will be a little lower. The bronchus over here will be aligned up exactly with the trachea. The head will be now turning a little to the left because its neck, the stem underneath that head, is oriented to the right. And now we've got some twisting going on. The purpose of this webinar is to describe the lung function associated with that pattern of twist. Underlying every human body on this planet is a little bit of that directional orientation. Extremely important concept to understand. And when you start looking at individuals who cannot breathe or have problems with breathing, more than likely underneath those problems is a little bit or a lot of what you see on that slide. Our goal is to reverse that slide, get that individual to go the other direction, and make them as easy as possible, make it as easy as possible for them to ventilate with her in the exact opposite position. We got to reportion her lungs, reposition her chest wall, and make her mindful of how to repattern activity when she's breathing better with her right upper lobes of her lung on the right and her left posterior lobes of her lung on the left. We really truly want to take a minute and draw that out. We really want to make the individuals that we're working with, we want to make them ventilate better up here on the right side, and we want to make them perfuse better on the left. Big P. This is where all the perfusion is occurring with that person standing. She's perfusing with all the blood down here in the base of that right lung. And she's ventilating with a lot of ventilation up here on this left lung. And so when she shifts to the other direction, this V is going to go smaller. This P is going to go smaller. This P is going to get larger. This V is going to get larger. We got to get blood over here on this left side. We got to get that rib cage down and that chest wall over here on that left side. We want a lot of perfusion happening on that left side. If she can't ventilate on that right side up here, she won't perfuse down here. Anything that's going to therefore open this lung up and anything that's going to close down this a little bit will be beneficial. And anything that's going to open up that mediastinum in the back, right over here in this back on the left side, so she can get a bellow in the front with her abdominal muscles is going to be good. The word reach is the same color. It's green, the same color I'm using for this demonstration. The minute I have her starting to reach with one arm, activity is going to change inside that lung. Fluid's going to move inside that lung. Filtration is going to move differently inside that lung. So how we ask her to move and what we ask her to do is going to be dependent on what her lung tissue is going to allow. The best way to ventilate somebody in a position that doesn't understand a word of what I'm saying is to make sure that they go out and they walk and they use both sets of arms and both sets of legs. They got to reach, they got to raise them, and they got to swing them. They got to pump up and down and get that lung to work. We're going to talk about patterned activity to get them to work better so they don't have to stay in that dominant state that they're in right now. Our left main stem bronchi is narrower and runs more horizontal than the right. The overall bronchus division, diameter, and distance from the center of the bronchial tree makes physical and physiological movement of the lung to the left somewhat more of a challenge. I just went over that, Jen. And our physical performance, noted through postural analysis, reflects this anatomical arrangement. This is a major slide. When we talk about these COVID, these breathing times that we're in right now, the respiratory function with this virus is now more important than ever to look at. The freedom to move from side to side for physiological blood flow and for physical stamina, for immune, the immune system to be able to work and develop the stamina it needs. This tree, this trunk has got to be in a position that allows us roots above and roots below, flow. So therefore, any way we can assist opening our chest wall cavities at the right upper anterior region of our chest wall and at the left lower posterior region to aid in expansion of the right apical lung, that would be zone 1 on the right side, and the left posterior lung, zone 3 on the left side, will help increase the overall diameter of the tracheal bronchial tree and decrease the fluid accumulated in this lung dead space. Alveolar ducts and sacs have some dead space. I want to talk about it a little bit. What is physiological dead space? It's the volume of air that's inhaled that does not take part in the gas exchange. We all have some of that. It's like I said earlier, if the ratio of that goes up, in other words, your dead space to your life space is going up and up and up, not down and down and down, your stamina, your immune system knows it, your fatigue level knows it, your gas knows it. You don't have any gas. You don't have no push. You have no pull because it remains in the conducting airways and never is pushed out. Number 2, it reaches alveolar tissue that are not perfusing or poorly perfused, possibly because of fluid accumulation. And we're going to talk about drainage in the next few weeks of that fluid. It retains the shape of the alveolar sac that has alveolar walls that are twisted into shapes that cannot be untwisted to open. That's dead space. I thought about it, and the best way to describe dead space is to look at something like this, a snorkel. Dead space can be increased and possibly better envisioned by imagining breathing through a long tube such as this snorkel. Snorkel is above the water and you're below the water. And what's in that tube is the dead space. Even though one end of the snorkel is open to the air, when the wearer breathes in, they inhale a significant quantity of air that remains in the snorkel from the previous exhalation. So every time you breathe in and push out, there's a certain amount of space in your body called dead space that you're really not, it's not healthy air, it's dead air. Now, if you don't use your lungs, yeah, you lose them. If you don't use your lungs, your dead space is like a snorkel that gets really long or a snorkel that gets really wide. And the more width to that snorkel and the more length to that snorkel, the more dead space you have and the less portion of live space you've got. So the airway sacs in your body that you do have that are alive are being challenged by all this dead airway space that you didn't get back because you didn't know how to make that snorkel smaller and more durable, more alive. To make it more smaller and more durable, you've got to make sure that the bellows that I just went over are moving. Things open on one side, close on the other. Things that go up on one side, go down on the other. I can bring my shoulder and my hip together as this hip and shoulder go apart. I can reach with this arm as this arm goes back. In other words, I can walk and I'm keeping my dead space ratios low to my live space. That's important. That's what we're really all about. Our goal is to maximize the live space in these bronchial roots that are coming from both the floor and from the head. You need to keep the nasal passages open. You need to keep the airway open so you can breathe at night. Otherwise, your necks are going to go forward. Things are going to collapse in the back of your throat. Tongues are going to get active. Chest walls are going to get tight. And you're going to be so stagnant when you walk, and you're going to push so much weight when it could be lifted by all this air that's being lost because it's not live space. Really important concept. A snorkel increases the person's dead space by adding even more airway that doesn't participate in the gas exchange. And I think some of these people that are on ventilators don't have the ability to get that dead space to come back to life. Now, if we prophylactically prevent it from happening to begin with, that is the dead space to happen by movement and keeping that dead space alive during the day that we're supposed to keep it alive, I think our chances of ventilatory assistance go way down. Our percentage of ventilatory assistance need goes way down. The total dead space or physiological dead space is the sum of the anatomical dead space, that'll be your bronchus tubes like snorkels, that don't open because of the torsion diameter limitations that we have when we're in poor posture. The twisting, for example, that might be accumulating over time because of the way you stand on one leg versus the other. Plus the alveolar dead space, those are your alveolar ducts and your sacs that don't open because of the torsional compression limitations that you didn't address. Torsional compression limitations that you didn't address. In other words, when was the last time you blew up a balloon? When was the last time you used a hula hoop? When was the last time you climbed a ladder or a tree? When did you reach with extreme range to unwind and decompress through when was the last time you decompressed by lengthening through anti-torsional activities? There is, however, a good ratio we all have for good to bad amounts of dead space. We retain needed carbon dioxide, warm up our air as it's brought in through our lungs, trap particles for matter, which mucus then lines up and traps it in the airways, and it humidifies our dry air, which improves the quality of our airway mucus. We all have that in that dead space area. In live space area, we retain that need. I'm going to reread this. We retain needed carbon dioxide, warm up air as it's brought in, trap particles of matter with mucus that lines the airways, and humidity, dry air, which improves the quality of air if we can get that dead space to come alive. About 1/3 of every resting breath we take has no change in oxygen. That's a lot. And carbon dioxide levels, usually in the range of 150 milliliters. So 1/3 of every resting breath we take has no change in oxygen and carbon dioxide levels. That means 2/3 of every breath you take is effective. With you not moving or with you staying on one side and with portions of lungs that are not brought back to life, that 1/3 can be up to 2/3, in some cases up to 4/5 of what you take when you take in a breath of air, which means you're only using 1/5 of the breath you take in as an exchange ratio. Limitations of chest wall movement and associated expansion of any or all of the portions of lung tissue will increase this range and decrease this dead space to life space ratio. I think, Jan, I'm going to go through this next part. The studies, did I include the study with this? Is the study on this? What I'd like to have you do is I'd like to have you go, if you're interested in this, go to this link, because this is a slide that talks about how curvature of the spine can be impeded or can occur because of lack of movement of the rib cage and lack of mechanics associated with the rib cage from respiratory muscles that aren't working correctly because of underlying lungs that are not working correctly. So if you're interested in that and you're interested in what total lung capacities can have on your spine, you might want to look at studies like this. The reason I threw that in there is because as some of you know that are listening, you PRI people out there that are listening, it's important for you to understand that lung capacity is directly related to spinal alignment, and spinal alignment is related to lung capacity. Ventilation to perfusion inequalities at the alveolar level, which would be your alveolar dead space level, secondary to alveolar malposition. That would be these little air sacs get in the wrong position. And then the chest wall then knows that. And when the chest wall starts to recognize that, and you recognize it, you start to habitually put yourself into what I would call bad positions. This can be increased by smoking and bronchitis and emphysema and asthma and pulmonary tension, viruses obviously, and pulmonary emboli. Jen, how far are we now? About how many slides do we have left?
Like 6, 7 more slides.
I really do.
Or the activity. We won't get to the activity. That's okay.
We won't probably get to that. But I want to get to at least the purpose.
Fine. Finish up the slides we have. We just won't get to the technique.
Okay. What I'm trying to do is really get to this thing called acute respiratory distress syndrome. You know, when we have this fluid buildup in our alveoli. So in the future with these webinar series, I really want to get to ARDS, distress, you know, stress to the lungs, and the respiratory distress associations with that, lung fluid accumulation. And what I did with this evening is led up to what creates fluid accumulation in a lung airway and a lung sac. And the answer is 3 things. 1, ongoing positional stance. You like one position. In other words, you can't get out of a position because the pattern associated with that position was built by how you breathe, how you perfuse, how you ventilate, and how you use your airways. 2, we like to collect fluid because we don't move our extremities to push things out. And 3, we like to collect fluid because we don't know how to use the diaphragm to pull air in when we're in states where we can't move and can't decompress. And that's really what this webinar is supposed to all be about. So I'm just today really hitting hard this underlying reason for keeping these bladders and the bellows, you know, moving. Otherwise, fluid accumulation and filtration are all going to be a challenge. And that filtration and fluid movement has to do with the shape that our lungs are put in, the portions, the lobes of our lungs that are then placed in, the surfaces that we now have in our lungs that are being challenged, and the fissures of our lungs that provide the ability to move. So in summary, the shape of our lungs, the positions in our lungs, the surfaces of our lungs from nearby organs, and the fissures of our lungs all provide one message to an anatomist or somebody looking at this body: movement. All those things say that there's one thing that our lungs have to do. You can't look at a muscle in the front of your leg and say, that leg is supposed to move. You can't look at a finger and say, that finger is supposed to move. But when you look at the lung, and somebody who's anatomically minded would say to you, when I look at that lung, because of that slide, says that lung has one purpose. That one purpose of that lung is to what, everybody? Move. Those fissures that you have on this, I think, is it coming up? Another slide, the fissures? Yeah. Those fissures tell you how that lung will move. They were meant to move under integrated guidance, compression, oscillation in segments. For an example, the right lung has an upper horizontal fissure that separates the upper from the middle. So I drew that right lung, here it is. This is called the horizontal fissure. You have an oblique fissure on both sides of your lung. On the left side, you have an oblique fissure separating the top from the bottom. And you have the same thing on the right side, top from the bottom. But you've got one middle lobe, and therefore you have one extra fissure called the horizontal fissure. The horizontal fissure arises from the right oblique fissure, and it follows the fourth intercostal space of your thorax, from the sternum until it meets the oblique fissure as it crosses into that right fifth rib, which is right there. That's your fifth rib. For those people taking PRI courses, we call that horizontal fissure a superior T4 syndrome site anatomically. This is where movement happens, called the superior T4 syndrome, that we talk about in some of the coursework regarding the brachial lung and brachial chest wall function. It complements segmental action of the apical chest wall, associated portions of the lung that are large or small under these chest walls, and cervical orientation related to the brachial tissue overlying this fissure. And so now we have a reason why not only do we like to be over the right side, because this bronchi that's more vertical on the right side with the trachea than the left, we also know that there's an oblique fissure here on the right side that allows us to turn our head back to the left through this fissure that allows the lung to collapse a little bit on its right side, taking this apical segment of this chest wall and lowering it and putting this right arm in front of us so we can balance over this right leg more easily. We don't have that fissure on the left side. We don't do that same activity. We are more right dominant extremity, upper extremity dominant than the left side. This is all the way the intrasegmental, intrasystem systems that we have work together, and it's all complementary of what you see when you look at lungs. You can look at those two lungs and learn so much about movement that's going on both underneath your carapace of bones and on the outside of your chest wall, which should include the arms and legs that are attached to that chest wall. The lungs tell all. The lungs tell all. They tell you how you move, how hard it is to move, and why you move in the direction you're moving. So there's that slide I was looking for, Jan. If you look at that slide, you'll see the horizontal fissure on top, the oblique fissure on both sides, and the horizontal fissure on the right side allows your upper half of your body to go back over to the left. So when you're standing on that right bronchus, you don't fall to the right. That horizontal fissure allows expansion through your chest wall from the lung to keep you more lined up over your right side so you can use your right arm to put food in your right mouth. The portion of the lungs that needs to move the most, especially on the left side, is the posterior basal portion of the lung and the posterior lateral regions of the chest and the abdomen. That's the portion of the lung that needs to move the most. The portion, I'm going to repeat this, I know we're running out of time, but I want to repeat this, Jen. The portion of the lungs that need to move the most, especially on the left side, is right here in the back of your lungs, right here, on this basal portion of the lung on the left side. And the posterior lateral regions and chest and abdomen, posterior lateral regions of the chest and abdomen. So that entire posterior mediastinum needs to be opening up, but more so on the left side than the right. Our lungs are portioned for that reason. That's how they're portioned. The pleura sacs, pleura fluid, inner and outer walls of the lobes allow the lungs to slide over each other during arm and leg raise and reach. For you to reach forward or back with an arm or chest wall, for you to reach forward or back with an arm, your chest wall has to rotate. If it doesn't rotate, you probably have some lung issues, underlying lung issues. It's an obligatory process. When you reach, you rotate. Our power, endurance, and composure, development, and behavior reflect how we complement hemi-chest raising, reaching, and rotation with the other side. Jen, how many more slides do I have?
4.
Okay. If everybody doesn't mind, I'll finish these 4 up and we'll call it a day. By performing chest wall repositioning and lung lobe reportioning activities to enhance our lack of movement at the lower posterior base of our lungs, drainage of stagnant lung fluid in these portions of the lungs, and compliance of the lower rib cage and mid-back, the overall ratio of dead space to live space will improve. All of that will improve. Take-home message. By reportioning activities with our lungs, by taking portions of our lungs that are not alive and repatterning those portions by positioning them for better drainage, for better fluid exchange, for better air exchange, all those things that I just put on that slide will improve. That's a very significant thing to live with and understand. And what can I say? I can't even tell you the date this was written, but postural drainage, 1971, Winifred Thacker wrote this book on postural drainage and respiratory control. And one of the diagrams in that book is how to get that drainage, how to get that posterior mediastinum, that posterior part of your back, to open up, which is what we talked about this evening, especially on the left side. And you can see that drainage. You can see the tree trunk that you saw earlier that was down on the floor is now up in the air, or it's being drained where the posterior medial side of your lower lung is being drained so they can go to the anterior lateral side of your lung. And anything that moves forward in your lung tissue is healthy. Ribs that come down accepts more air, accepts more fluid of blood, flow of blood, and then more exchange and perfusion. And remember, on the left side, we need more perfusion than the right. So putting somebody in a position where their back is open and their arms are above their head and they're reaching with their arms and their legs makes sense to me. And this was a picture we saw back in 1971. So in the year 2020, we can do the same kind of thing with a technique called the standing supported left glute push. Jen's going to talk to you about that here in a few minutes. I want to remind you that if there's one thing to survive the infection that we're talking about, this COVID, but what's next? Some COVID-19 patients need rehab to walk, talk, and problem solve. It's one thing to survive the infection, but what's next? Walk, talk, and problem solve. So this article that you can go to and read about saying when they get these COVID-19 patients out of the hospital, they've got to walk and they got to talk. And that's kind of what we talked about this evening. I don't think I need to say anything more about that slide, Jen. Does that make sense to you, what I'm trying to do there? We're going to talk about a lot more about drainage in the weeks to come. Jen, what about this slide? Tell me about this slide while I take a drink.
So I included some information on the standing supported left glute push, and we're not going to get into more detail about it tonight. You guys have some slides. That same information was posted to our blog last week, so you can go and read that. We will get into this technique, trust me, because it's one of Ron's favorites and one that he really wants to get into with you. But since we're running over tonight, we won't get into it tonight, but we will get into this technique. As Ron said, these first couple weeks, maybe first 2 or 3 weeks, we're kind of setting the foundation for this whole series. So we kind of have to cover some terminology and concepts and lung mechanics and functions of the lung before we can really get into the treatment and the techniques and the recommendations that we have for you all. So thanks for joining us again tonight. I apologize. It sounds like the quality wasn't the highest tonight. We made a change that we were hoping was for the better, and it sounds like it wasn't. So we're going to make a change back tomorrow. But I think it all was fine. I just don't think it synced up a couple times with internet connection. So I apologize about that. But we will get it back to where we had it last week, and we look forward to one other thing. Flip this around here, Ron.
Yeah.
Next week, we will not have a webinar because Ron is actually a guest on another webinar next week. And so he will be on the AAPMD, the American Academy of Physiological Medicine and Dentistry webinar. It is at 7 o'clock Central Time, so it's an hour later. And I already have a link to that on our webinars page. And we will be posting about that on our blog and social media here in the next week as well. But his topic there is airway management, implementing interdisciplinary concepts associated with forward locomotor movement. So if you're looking for something to do next Tuesday, you won't be joining us here from Lincoln, Nebraska per se, but you will be joining Ron on the AAPMD webinar with Dr. Howie Hinden and their group. And he's excited about that opportunity. So we'll be back here with this webinar series in 2 weeks. But in the meantime, if you want to check this out next week, feel free to as well. But thanks again for joining us and have a great evening.
Thank you, everybody.